Hello there, my dear and esteemed listeners. My name is Nath Arwa, and I'm a clinical pharmacist by profession and by training, and I'm the founder of Progressive Pharmacotherapy Consultants, the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial to us, and they are non-negotiable as well. Now we seek to remain your premier virtual clinical pharmacy institute to build your capacity for optimal pharmacotherapy outcomes, even as you deliver services to your clients. Now, I would like to welcome you to sit back and spare me part of your very precious time, even as I share tips on how best to make decisions in the line of duty. So welcome to part 6 of our series on pharmacotherapy MCQs. So in the first case, if 70% of Staphylococcus aureus isolates in your ICU are MRSA, which anti-staphylococcal antibiotic would you use to treat suspected ventilator-associated pneumonia? Would you opt for piperacillin tazobactam infused at a dose of 4.5 grams in 100 ml of normal saline infused over 4 hours continuously 3 times a day? Or would you opt for IV oxacillin? Or would you infuse vancomycin over 1.5 hours thrice daily? Or would you administer 400 milligrams of moxifloxacin intravenously over an hour once a day? I'll give you 10 seconds to make the correct decision. So I would opt for infusing vancomycin. Now, since there is 70% of our isolates in the ICU that are MRSA, vancomycin would be indicated. Oxacillin and piperacillin tazobactam have absolutely no MRSA activity. Now, moxifloxacin has some MRSA activity, but it is not recommended for treatment of VAP. It may be used in some cases of community-acquired MRSA pneumonia if the MICs are fairly low. So I would not opt for it in this particular case. Let's move to the next question. Now, all of the following may increase triglycerides except, is it protease inhibitors used in the management of HIV? Or would it be bile acid sequestrants like cholestyramine? Or would it be fish oil? Or would it be oral estrogens? I'll give you 10 seconds to make the correct choice. In my opinion, C is the correct answer. Agents that can cause elevated triglycerides include oral estrogens, glucocorticoids, bile acid sequestrants, protease inhibitors, retinoic acid, anabolic steroids, sirolimus, raloxifene, if I remember well, tamoxifen, most beta blockers with an exception of carvedilol, and even the thiazide diuretics can cause this problem. So in that case, the exception here would be fish oil. So I would opt for option C. Next slide. So R&M is a 69-year-old male patient who weighs 236 pounds and is 5 feet 8 tall. And the past medical history includes hypertension, dyslipidemia, diabetes mellitus, congestive heart failure with a reduced ejection fraction. And the current medication list includes a gram of metformin taken twice daily after food, basal insulin. He administers glargine at a dose of 20 units at bedtime. He also takes an SU glipizide 10 milligrams twice a day. He is also on atorvastatin 40 milligrams at bedtime. He takes lisinopril 20 milligrams orally once a day, and he's also on 12.5 milligrams of carvedilol twice daily. He also receives a low dose of 20 milligrams of furosemide orally once a day in the early part of the day, and he also receives 12.5 milligrams of spironolactone once daily. So R&M complains of several hypoglycemic episodes on the days he opts to fast, to skip his meals, or when he eats late. So which of the following would be the most appropriate options for managing his type 2 diabetes mellitus? Would it be discontinue glipizide and add pioglitazone 30 milligrams orally once a day? Would you discontinue glipizide and add dapagliflozin 10 milligrams once a day? Would you discontinue the glipizide and add dulaglutide 0.75 milligrams administered subcutaneously once weekly on Tuesdays? Or would you increase the basal insulin to 40 units and add short-acting Lispro sliding scale? I'll give you 10 seconds to make the correct choice. Personally, I would settle for C. Now, the SU glipizide should be discontinued because it increases insulin secretion, and one of its main side effects is hypoglycemia. Now, since this fellow doesn't eat all meals consistently, there are times he skips meals, this is contributing to his episodes of hypo, and should therefore not be using this SU. Now, I saw pioglitazone somewhere. It has a black box warning. It isn't a good option for him since he already has heart failure, and pioglitazone would exacerbate this grossly. Now, dapagliflozin isn't a good option for him since it works by reducing glucose absorption at the kidney level, and this could increase volume depletion in our patient who is already on diuretics. Remember, there is furosemide there, and there is aldactone or spironolactone for that matter. Now, adding dulaglutide 0.75 milligrams once weekly would simplify his regimen and drop the A1C. Now, GLP-1 agonists can drop A1C by an average of 1 to 1.5. Now, option D isn't ideal either because increasing the glargine dose and adding the Bolus sliding scale will just worsen the hypoglycemia. Since the sliding scale insulin is potentially inappropriate according to the Beers criteria, considering his age. So if we look at his ideal body weight is 63.4. His body weight is 107.3, so he's around 120% overweight. And when we base on a body weight of 84, the creatinine clearance from a quick computation is around 82.8 milliliters per minute. That would make me biased towards option C. The others wouldn't be very optimal for this particular patient. Let's move to the next slide. So the same patient on the same medication complains of several episodes of hypo on the days he skips meals or eats late. So what should be the goal A1C for this particular patient? So I'll give you 10 seconds to choose from the options below. Would it be below 6.5, below 7, below 7.5, or below 8.5? I'll give you 10 seconds to choose. C is the correct answer. Now our patient RNM is an elderly patient above 65, which qualifies him for a goal of below 7.5. Although he has several comorbidities, there is congestive heart failure, his stage 2 kidney disease with a creatinine clearance of 82.8, and is hypertensive, he doesn't meet the criteria of at least 3 chronic illnesses, that the criteria as per the guidelines to have a less stringent A1C goal of below 8 states. Now that list consists of incontinence, stage 3 kidney disease, MI, and stroke. Remember, he's still stage 2, so he doesn't qualify for the below 6.5. He only meets 2 of those. Now, in order to meet the goal of below 8.5, a patient must qualify with the presence of one of the following. Should be single end stage chronic illness, e.g. stage 3 or stage 4. There should be congestive heart failure. It should be oxygen dependent for lung disease such as COPD, cystic fibrosis, and the rest. Or there should be chronic kidney disease that requires twice to thrice weekly dialysis. Or there should be some form of uncontrolled metastatic cancer. Now the goal of below 6 only applies to healthy non-elderly adults according to the AACE stroke ACE. So I would settle for option C. Let's move to the next slide. So it reads, to which NYHA category does a patient with the following characteristics belong? He has marked limitation of physical activity, is comfortable at rest, but ordinary activity results in symptoms of heart failure. Is he stage C, stage D, class 3, or class 4? I'll give you 10 seconds to to make the correct choice. So he belongs to class 3. Now the guidelines state that class 3 is defined as an individual who has marked limitation of physical activity, who is comfortable at rest, but ordinary physical activity results in symptoms of heart failure. Class 4 applies to an individual who is unable to carry out any physical activity without symptoms of heart failure, or who has symptoms at rest. Now, stages A to D aren't used by the NYHA functional classification. Yeah, so that makes options A and B wrong. Stage D applies to individuals with refractory heart failure, which requires specialized interventions, while stage C applies to individuals with structural heart diseases with prior or current symptoms of heart failure. That's just about the way. So let's move to the next question, which reads, which of the following medications are known to prevent heart failure in patients with MI? Are they statins? Are they S inhibitors or ARBs? Are they evidence-based beta blockers such as bisoprolol, metoprolol, succinate, or carvedilol? Or are all of the above known to prevent heart failure in patients with MI? I'll give you 10 seconds to make the correct therapeutic choice. So let's move to the next slide. In my option, D is the correct answer. All of the above are known to prevent heart failure in this category of patients. Now the guidelines state that in all patients with a recent or remote history of MI or acute coronary syndrome, statins should be used to prevent symptomatic heart failure and cardiovascular events. Those with atherosclerotic disease are more likely to develop heart failure. Therefore, aggressive treatment with statins, using high-intensity statins, can help reduce the likelihood of heart failure in these at-risk patients. The guidelines also state that in all patients with recent or remote history of MI or SCS or a reduced ejection fraction, ACE inhibitors should be used to prevent symptomatic heart failure and to reduce mortality as well. Now, ARBs would be appropriate in patients who do not tolerate ACE inhibitors. Remember, there are those who have that stubborn, dry, irritating cough when they are put on ACE inhibitors. So this can also be applied to beta blockers as well. Patients with a recent or remote history of MI or SCS and a reduced ejection fraction should use evidence-based beta blockers to reduce mortality. Now, in addition, ACE inhibitors, beta blockers should be used in all patients with reduced ejection fraction to prevent symptomatic heart failure, even if they don't have a history of MI. That is very crucial. Crucial, by the way. Now let's move to the next slide, which says, in a study where the investigators measured decreases in weight in 120 patients over 90 days of initiating a hypothetical drug, the mean decrease in their weight was 16 pounds with a standard error of mean of 24.2 pounds. So what is the 95% confidence interval for the decrease in weight with this hypothetical drug? And what is the interpretation of this confidence interval? Is it 8.23 to 24.23 pounds? Is it 11.8 to 27.8 pounds? Or is it 95 to 26.5 pounds? Or is it finally 12.4 to 18.4 pounds? I'll give you 10 seconds to compute and make the right choice. So that slide displays how I got to A as the correct option. I know you are good statisticians, so I'll give you 6 seconds to have a look at the computation before I move to the next slide. So in our next question, which of the following is a dichotomous variable? Is it gender? Is it pain yes or pain no? Is it alive or dead? Or are all the three correct? I'll give you 10 seconds to make the correct choice. Opinion? All the three are correct. Now, dichotomous data refers to category data that has only two categories or two answer choices. All of the three have only two categories. It's either gender female or male, and it's either the patient has pain or the patient is not in pain, and it's either the patient is alive or dead. There are no in-betweens. Let's move to the next slide, which reads, a 37-year-old Caucasian man with no past medical history presents to your clinic. His average BP reading is 146 systolic, 87 diastolic, with a heart rate of 65. The CBC and complete metabolic panel are within normal limits. Which of the following is the best way to manage his hypertension according to JNC8? Is it lifestyle modification? Or would it be lifestyle modification together with amlodipine 2.5 orally once a day? Or would it be lifestyle modification with hydrochlorothiazide 12.5 milligrams in the morning? Or are both B and C appropriate options? I'll give you 10 seconds to make the correct choice. So I would pick on option D. Now, this fellow is 37, below the age of 60, and is considered a member of the general population since he has no known medical history and he is Caucasian. Now, JNC8 does not address definitions of hypertension and prehypertension, but defines the thresholds for initiating pharmacologic therapy. Now, medications should be initiated when systolic blood pressure is 140 or higher. For Caucasians, either a thiazide type diuretic, an S inhibitor, or an ARB, or a calcium channel blocker should be initiated. So both choices B and C are appropriate options for starting this gentleman. Let's move to the next slide. So Our patient JSK is a 63-year-old male patient with a newly diagnosed diabetes mellitus. His past medical history includes hypertension, for which he takes 5 milligrams of amlodipine once daily. He also takes 25 milligrams of hydrochlorothiazide in the morning after breakfast. And his cholesterol panel includes total cholesterol of 222 milligrams, low density lipids 105, triglycerides of 330, and HDL of 51. His vitals include a BP of 125/75, a heart rate of 70. His physician put him on metformin, 500 milligrams, taken orally twice daily after meals. So besides metformin, which pharmacologic regimen should he be started on at your hospital? Should it be high intensity statin, atorvastatin 80 milligrams taken at bedtime? Or should he take rosuvastatin at a dose of 10 milligrams at bedtime? Or would you opt for gemfibrozil 600 milligrams taken twice daily? Or would you settle for simvastatin 40 milligrams once daily? I'll give you 10 seconds to make the correct choice. For A. Now, Mr. JSK has diabetes. His age falls between 40 and 75 years. And as we can see, he has an LDL between 70 and 189, which places him in one of the 4 statin benefit groups. Now, these characteristics also warrant using the pooled cohort risk assessment equation to estimate his 10-year ASCVD risk. Now, using this risk estimator and assuming he is a non-smoker and he is Caucasian, his 10-year ASCVD risk is 22.1%. Now, since this value is greater than 7.5%, he should receive high intensity statin therapy. Now, when you look at those options, rosuvastatin 10 milligrams and simvastatin 40 milligrams are considered moderate intensity statin therapies. So that makes answers B and D wrong. And gemfibrozil is not a statin, so that also automatically knocks off option C. And atorvastatin administered at a dose of 80 milligrams qualifies as a high intensity statin therapy. So I would settle for option A. Let's move to the next slide. Now the question reads, in a publication, the observed mean weight of 200 patients was reported as 69.4 plus minus 9.3 kg. If 9.3 kg is the standard deviation, calculate the SEM. Is it 60.1, or is it 0.658 kilograms, or is it 9.3 kilograms, or is it 17.94 kilograms? I'll give you 10 seconds to make a decision. So since you're all good statisticians, I'll give you another 6 seconds to look at how I arrived at option B as the correct answer. So my highly esteemed viewers and listeners, that brings us to the end of part 6 of our series, and I hope you gleaned useful tips that will help you deliver effective and safe pharmacotherapy in your line of duty. Now, if this video helped you in any way, I humbly urge you to remember to give it a thumbs up and to subscribe to my YouTube channel, the Progressive Pharmacotherapy Consultants. I promise you the best is yet to come, and I'll consistently upload high value pharmacotherapy material in this channel, even as we journey together in delivering safe pharmacotherapy while laying emphasis on patient safety. So I thank you very much for viewing and for listening, and I hope to interact with you in the next editions of our series. Thank you very much.